morning. Hi, everybody. We're really going to get started this time, which is not too bad. First, I want to say thank you so much for joining us. Welcome to the 2025 National GVHD Symposium. It is genuinely an honor to convene here today, both virtually and in person. We are united by our shared commitment to progress GVHD research and care and advocacy. And the hosting of this symposium by the James at the Ohio State University is, we could not have done this without them. And so thank you, we greatly appreciate it. At the heart of today's event is the mission of the Meredith Cowden Foundation. We want to increase the number of blood and marrow transplant survivors, raise awareness of transplant complications and late effects, and reduce their impact. The foundation is dedicated to empowering survivors and families by connecting and educating healthcare professionals and the public, as well as supporting programs to improve post-transplant quality of life. And this day exemplifies our commitment, bringing together clinicians and researchers, patients and advocates to share all of our knowledge, develop hope, and move forward with innovation. Deep gratitude goes to our organizing committee, our presenting experts, our generous sponsors, and especially our attendees. The Cowden Foundation Committee has shaped a program that I think is going to be so insightful and provide us with a lot of really good information and ways to move forward. And your participation is crucial so that we can collectively advance awareness, prevention, and treatment of GVHD. I'm going to quickly go over the schedule of the day. So in the morning, we're going to have parallel tracks. And so if you're interested, I can't see any of you. Okay, so if you're interested in the scientific tracks, they will be in this room. If you are interested in the patient and caregiver tracks, they will be across the way in the Scioto room. If you get lost, I'm really sorry, I don't know how. I feel like you'll figure it out. So this morning, what we have are some fantastic presentations. Over here, we're going to have a case presentation. And then across the way, there's lifestyle medicine. There are nutrition interventions, neurocognitive care, late effects, with leadership from experts from UPMC and UC Health, The Ohio State University, and Memorial Sloan Kettering. And then during midday, we're going to have, it's sort of like a group of things together. So we're gonna, the people in the patient sessions are gonna come back over here, and we're going to have our keynote presentation by Dr. Andrew Harris, as well as a panel for Q&A. You have very large pieces of paper with a lot of space for questions. So please think of questions as they come, write them down. And if you could have those to us by, 11:30-ish, please turn those into that table over there. Keen is waving. Yeah. And so that's going to happen during the middle of the day, and then we're going to end the day with lung and oral GVHD, rehab strategies, and a sound bath. So the lung and oral GVHD will be in here, the rehab and sound bath will be across the way, and then what we're going to do is finish things up, and then we're going to drink and eat, because why not? So I want to say to our virtual attendees, please make sure that you follow the instructions that you received for participation in the Q&A sessions. We're going to have somebody manning the chat, and so if you type in your question, it will be, we'll make sure that we get to it. If we don't get to it live, then we'll make sure that we're able to answer it later. with follow-up. And we really appreciate the fact, I know that there are two different links, and so we appreciate the ability to bounce back and forth and have flexibility with that. As we move through today's sessions, I feel like this is an Irish toast, because I wrote it out like, may our conversations and collaborations honor, it just feels like an Irish toast. Like, as you slide down the banister of life, may the splinters never point the wrong way, But so in this case, that is true, please. And also, like, hopefully our collaborations and our conversations will honor what it is that the Cowden Foundation and my father specifically have worked so hard to develop, which is building a future in which survivors thrive, knowledge grows, and the impact of GVHD is diminished. Thank you again. Marcos, do you want to say anything? Or you want to wave? Just wave. Okay, cool. Okay, so, I know. Okay, so with that, I'm going to turn things over to Marcos, and then we're going to get started. Thank you so much.
So good morning. My name is Marcos de Lima, and I work here at the James. But I'll tell you, those who know me love that I love to tell a story. So before I do that, though, this meeting is not quite the same without Jerry and Marty here, right? I mean, are they online? They should be. Hey, Jerry. So 2012, I moved from Houston to Cleveland. And I got to Cleveland, and they told me, you know what, there is this foundation. It's a couple here whose daughter has been involved with this, and for a variety of reasons. And she met Kalaisho at the Cleveland Clinic, treated her. Why don't you go talk to them? And so I did, and found out that this was, and still is, the only such enterprise in the United States. A foundation dedicated to this, from the outside, a rare complication of transplant. For us here, not rare, right? But if you look at 300 million Americans, this is like an alien planet, right? And has been through advocacy like this that industry, academic centers, out there, clinics start paying attention to this. So this is vital, right? Vital, because we know that if we don't make noise, you are ignored, right? This is how society works. And so I came to admire this couple, and I admire Meredith very much so. So this was 2012 for me. For you, when was founded, when the foundation was created? I forgot. 2007, so I came late to the game. But since then, this is why we're doing this here, right? Because of this connection and, obviously for the topic, it's very dear to us, and obviously, so anyways, so that's the story. And finally, I want to welcome all to Columbus and all those who are already here. And thanks for coming, because we have several of our patients here, and this is the reason why we do what we do, right? So thank you all for coming. So let the games begin.
So now what we're going to do is, I wanted to make a note really fast because I thought it was funny, and also I was like, that's so wrong. So we're going to start off this first session with how I treat chronic GVHD in the scientific space, and then across the way, Dr. Golubic is going to be speaking about lifestyle medicine. And I will say for the how I treat GVHD session, it is not my specific medical advisory group. Foundation, it just says the Meredith A. Cowden Medical Advisory Group. And so I just wanted to clarify, it's not my personal team. Yeah. So with that, have a great day, and thank you so much.
Oh, perfect. I was like, what's
Answer for you guys. We have the podium mic and we have two additional mics.
Cool.
They're currently muted. To unmute them, you just click the button.
Okay.
Just so they don't make noise when
Got it,
you know
got it,
them.
got it.
So you guys are free to pass those and just make sure you click the
Click them first.
Thank you. And you can take this off if you need a third mic.
Okay.
Totally up to you. Do you want
And this-
the podium to the side? Do you want me to just move it over for this? So that it's not blocking? Right.
Sure. And then we can just have these.
Yeah, feel free to take that. I can get it for you. Sorry,
And then,
it's tricky.
Sorry, this one's the advancer?
Yep. Oh, you'll want to go, the big green button is forward. There you go.
Okay.
Cool. I'm sharing to the virtual as well. I'm controlling that all in the back.
Cool. Hello. Grab one. Marcos. Dr. DeLima. All right, well, welcome everyone. I will tell you, I'm Annie M. I'm one of the transplant physicians at UPMC. I'm joined by this esteemed panel. Andy Harris is going to get, is our keynote speaker and is going to get a long introduction later. But two of our other members of several, but two of our other esteemed members are Betty Hamilton, who's at the Cleveland Clinic, and then you just heard from Dr. DeLima, Marcos DeLima. Did I say senior? Esteemed and senior. So Dr. Harris, Dr. Hamilton, Dr. DeLima. And I will tell you that this originally was going to be a talk on infection complications in transplant from a speaker from the NIH. And unfortunately, due to governmental restrictions, we had to pivot last minute. So we thought this would be fun, and we are going to do a case discussion and discuss among this panel some of the complicated topics in chronic GVHD for which we don't have great data, and just hear from our panel about kind of different practices. So I'm going to keep us on time. I'm going to make sure we end on time. So I might rush through some of these things to get to some of the meatier questions. I should also, yes. Okay, so just real quick, this is a 57-year-old male. He was diagnosed with AML. It was FLT3 ITD mutated, NPM1 mutated. He had CNS involvement at the time of diagnosis. He underwent induction and had some complications during induction. He underwent HIDEC consolidation, also some complications, as you can see. But ultimately, he underwent a matched unrelated donor, peripheral blood stem cell transplant. Patient donor's CMV was mismatched, ABO was matched. His conditioning regimen was with Flu-Bu-4, and his GVHD prophylaxis was with post-transplant Cy, Tacro, and MMF. His transplant course was complicated by one seizure episode. He did have that prior history of seizures. PRES was ruled out. His Keppra dose was increased. So, wanted to start, and we won't spend too much time on this question because there's other kind of good topics to talk about, but, kind of in this era of the evolution of GVHD prophylaxis, we'd love to hear from the panel about what prophylactic strategies you guys are using at your various institutions. And perhaps in addition to that, with that change and with this evolution recently and the changes of the standard of care, how has that impacted either rates of GVHD, characteristics, et cetera? Did I mention all the institutions you guys are from? I didn't. Sloan Kettering and Cleveland Clinic, and then obviously The Ohio State. Anyone can jump in, or we can go down the line, up to you.
I can start as the pediatrician in the room. So I know on the adult side, most centers have, for their unrelated donors, really across the board gone to post-transplant cyclophosphamide for all patients. That really hasn't happened yet in pediatrics. There are some centers that are adopting that. There are others that are not. And there are things we think about in pediatrics that we don't necessarily in our older adults that are getting transplant, like the extra alkylator exposure and potential impact on fertility and growth and development for our patients. So we're still primarily in these settings using calcineurin inhibitors and short course methotrexate as our GVHD prophylaxis. However, in our unrelated donor setting, and then also in our patients that are getting transplants for non-malignant conditions, we're adding in ATG, and we're using population-based PK dosing of ATG that's been shown to really not only reduce the incidence of graft versus host disease, but also increase, based on how we do the dosing of it, the immune reconstitution post-transplant to minimize the risk for infection. So that's really what we tend to do with most of our patients. Now in the cord blood setting, we still tend to use tacrolimus and mycophenolate as our GVHD prophylaxis. And then for our mismatched donors or haplo donors, that's where we tend to use either PT side or alpha beta T cell depleted, T cell B cell depleted grafts. And that's obviously still a very hot topic of which one of those is going to end up being the best approach going forward in that setting.
Yeah, can I actually ask a quick question before we go on? I actually don't know this answer. Is there data in the pediatric setting for PTCy for matched unrelated donors?
There is some.
Not as robust as adults.
Not as robust as adults, but in the mismatched setting, the two approaches that tend to be used most are the PTCy or abatacept. The problem with abatacept was that we saw that while it reduced the incidence of acute GVHD, chronic GVHD rates were not decreased in the slightest. We're seeing very high rates with that. Now, that's trying to be addressed by extending the course of abatacept to see if that can reduce the chronic GVHD incidence, or if that's just going to kick the can down the road and we're going to see the chronic GVHD later. But we're not participating on that study, so we're using PTCy preferentially in our patients.
Oh, so you just reminded me that kids are not just a small adult, right? Because the field for adults has changed a little faster than that, right? I mean, in post-transplant, cyclophosphamide has taken the field by storm, right? Which brings, for those here who are not exactly in the clinical side of things, or our patients or caregivers, it gives us options, right? I mean, we evolved, if you will, from one size fits all to a variety of settings, which reflects also the fact that we have so many donor options now, which is great, but also adds another layer, right, of complexity, because immune reconstitution becomes more complicated intrinsically because there's so many HLA mismatches, or the combination between these HLA mismatches and then the changes in GVHD prophylaxis. So you don't know even at the end who is who. But the reality is that we live in an era where, when I started doing this, I would see a person of color coming for transplant. And in the vast majority of the times, I would say, no deal. I have no donors. I have no ways to do this. It would simply be impossible because the registry would not find a donor. If not lucky enough to have a donor in the family who was fully matched, you are out of luck. So this has changed dramatically because of these mismatched transplants, and in the United States because of post-transplant cyclophosphamide. So which is great, but it then brings another layer of different stories, which is how to learn to recover this immune system and protect people during that transition and so on. So anyways, but remember, kids are not just small adults. See, I'm well-trained.
I agree with all and just make the couple points that, just like Marco said, PTCy, although it has drastically reduced the incidence of GVHD, particularly severe acute GVHD, it's not perfect. And our field is really is very interested in improving upon that, reducing the doses of Cy, adding other novel agents to it. And it really, chronic GVHD has not been fully eliminated. I mean, we see through our chronic GVHD consortium that, the incidence of chronic GVHD, we're still trying to understand if the characteristics are the same as with traditional calcineurin inhibitor methotrexate, so.
Yeah, well, thank you all. Yeah, I would agree. I would say that for us at our institution, we take pause with myeloablative conditioning in PTCy because some patients, it's really tough to tolerate. And so, I'm looking forward to the data that comes out about what's different about chronic GVHD in the PTCy era as well, because that'll be very interesting. I think all of us have kind of anecdotal experiences about that, but I'm interested to see the data. So we'll go on with the case. So this patient ended up having biopsy-proven GI GVHD. He responded to steroids, did fine with that. He was able to taper off that. He did have bone marrow biopsy that was positive for MRD, so he started gilteritinib maintenance. And then during the tacrolimus taper, developed a new skin rash. So again, we started on steroids and was taper off by some reasonable amount of time. That is blank. But responded to steroids and did fine with that. So this is then like later on post-transplant. I will say that this case, some of the details have been adjusted for the purposes of discussion. So if you think about it, we weren't using PTCy a year and a half ago, right? But just pretend. So a year and a half, 1.5 years post-transplant, he had about 15-pound weight loss over 6 months. He had dry eyes and discomfort in his eyes. So he was referred to ophthalmology as well as our GVHD clinic. You can see his pulmonary function tests pre-transplant, day 100. He had 1 year PFTs, and then you can see at the time of referral what his PFTs looked like. So at time of referral to us in the GVHD clinic, you can see the significant decline in FEV1, and then we did repeat this just to confirm, that this was, just to confirm that this was, a true decline. So, of course, most of us would start him on FAM. What would you do now? Do you start steroids alone up front for all patients? Do you ever consider non-steroids up front? Or is it just, let's just give him steroids, because that's easy?
Okay, all right. So we typically sort of just making sure that acknowledging a full pulmonary workup, doing a high-resolution non-contrast CAT scan. We oftentimes work with our pulmonologist colleagues to just make sure we rule out infection and other causes. Given, obviously, the constellation of symptoms, as patient seems like they have a diagnosis of chronic graft-versus-host disease, and FAM therapy is, well tolerated and has been shown to reduce the progression of BOS, or bronchiolitis obliterans. I think when available, enrolling on a clinical trial is something that we always consider in chronic graft-versus-host disease. There is actually sort of ongoing trials because about not using steroids up front. I think as a field, we all recognize how toxic corticosteroids can be. And in chronic GVHD, the response rates are less than 50% to first line, even though steroids do remain the first line therapy for chronic GVHD. Response rates and durable response rates are less than 50%. So there's a lot of interest in our field to use non-steroid approaches. So I would hopefully offer this patient a clinical trial to study non-steroid approaches. A lot of times in real clinical practice, it'll depend on, this patient has been on steroids before. If this patient had developed diabetes and irritability and all these terrible side effects of steroids, it is a real consideration to minimize the steroid use.
Let me ask you this. Do you, I remember you and Navneet Majhel were doing this proteomics of breath. Where does that stand? I mean, I haven't seen a follow-up on that. I always thought that was so neat. You may want to
Thanks, Marcos.
Have you published this yet, Betty?
Making me feel bad about not publishing that paper yet.
That was a great idea, but where did it?
So what Marcos is referring to is that we did a study where we evaluated breath analysis. I think many people are aware of like breath analysis and like a breathalyzer test. So there is some data in being able to detect changes in breath metabolomics in different diseases, like liver disease, inflammatory bowel diseases, and things like that. And so this was a collaboration with our pulmonologists in which we evaluated breath and the changes in a breath signature, more as it related to GI graft versus host disease, with the hypothesis that the microbiome changes and bacterial changes lead to changes in the breath signature. We have done a follow-up study where we actually are correlating longitudinal breath samples and stool samples, and the manuscript is currently being written. But in theory, yes, this potentially could be used in sort of the lung setting as well, but has to, obviously be studied.
So I think this is what this sounds like is an isolated pulmonary chronic GVHD case, which is a great opportunity for me, putting my pediatrician hat on, to show some of the limitations and challenges that we have. So if this was a 7-year-old patient, we would be able to get these PFTs and make this diagnosis. But we are very limited in what we have approved in the pediatric setting below 12 years of age or below 40 kilograms, depending on, we talk about as far as additional agents for graft versus host disease. So we use a lot of things off-label, but some of the newer agents, there's a lot of challenge in trying to get access to those for these younger children. Thankfully, now we have clinical trials that are getting ready to get underway with some of these newer agents like belumosudil and axatilimab in pediatrics, but they're not enrolling yet. If you back this up from a 7-year-old down to a 3-year-old who we can't get PFTs in, we really don't have any really well-established testing to try to monitor lung function. There's papers coming out looking at, parametric response mapping with CT scans. We have, hyperpolarized 129 xenon gas stuff that's being done out of Cincinnati. And then we have the multiple breath washout testing, which in the most recent pediatric ATS guidelines is being recommended for baseline screening and then at diagnosis, but not a surveillance in between. So there's a big gap there as well. So a lot of centers, unfortunately, are waiting till these patients are symptomatic. And by the time the patients are symptomatic, they've had a severe decline in their lung function. So even identifying lung GVHD, particularly in our young patients, is really, really challenging and a really big unmet need that I hope that we're going to hear a lot about later on. So I know that we have a talk about that this afternoon that specifically addresses this challenge. But then we look at our treatments right now in pediatrics. The only agents that we have approved below 40 kilograms or 12 years of age are steroids, which really isn't technically approved, but it's widely accepted, and ibrutinib, which we talk to all the pediatric chronic GVHD people. None of us use because we don't think it's all that effective. And our
Adults
patients
don't use it that much either.
And patients tend to feel miserable on it. So unless you can get something off label and you have to get insurance approval for that, we're really limited in our treatment. So up front, it's still steroids for us because we really don't have access to anything else. And we have to really advocate for our patients when we have to move beyond steroids, given the limited options to actually have approval. And this is something that I think that we need to try to figure out how to address on a federal level, getting these younger patients included up front in studies so that way we can learn how to use these drugs safely and then get indications so I have tools in my tool bag that I can use to treat these kids when they present.
Yes. So for all of our industry partners, pediatrics up front. And I'm looking around. I see one pediatrician, but I don't know if there are others. But anyway, so it's really nice to have that perspective because we don't think about these things on the adult side for sure. Okay, so just going on with the case, I want to be respectful of time for our next speaker. This patient ultimately was started on FAM, autologous serum eye drops. He actually had a lot of difficulty with steroids previously for acute GVHD, so really pushed hard against steroids. He did decline participation in a clinical trial looking at upfront AXA-Rux versus steroids because of the 1/3 chance of receiving steroids. Ultimately, he worsened. He was admitted with MAC pneumonia infection, and even after resolution of his infection, he really had declined again in his PFTs and symptomatically as well.
Right, so he did not receive systemic therapy at that time? He didn't want steroids, but when did he get started on nothing, just FAM?
No, so this case is a little bit, like I said, fabricated. So in real life, yes, like he wasn't quite. Yes, he was not started on any systemic therapy. Okay. Yes, and symptomatically it was just mild at the time. So ultimately, after this episode, he was started on steroids and belumosudil, with the idea that to try to get him off steroids more quickly, and because, and I think we can talk about this, but the idea that belumosudil being antifibrotic would be good in this setting for him in particular. So he did have symptomatic improvement on this therapy, but what I wanted to get to, hopefully, is, I think a really interesting question, which is, especially in the setting of things like lung and some of these other difficult to treat organs, how long do you wait before switching or adding treatments? And that also gets to the question of what determines clinical response in some of these organs that where stability might be a victory. I think this is always a really tricky clinical question, so curious to hear people's input on that.
So where is Steve when we need him? No, he's with the patients now. But this is where this becomes a little art, right? Yeah, I mean, it is a lot on the eyes of the beholder. I hate to say that. Especially because, as you alluded to with the lung GVHD, a lot of what we do is not exactly based on direct measurements, right? I mean, it's just the nature of the beast. Dry eyes, subtle symptoms everywhere. So we can, obviously our field has tried to quantify this very elegantly. We have all the scores, all the GVHD took a decade or more. Steve is Dr. Pavlevich, who just left here, who left who left the NIH as well recently, but he spearheaded a variety of initiatives. He was the heart and soul of a lot of what we do in terms of grading and defining response and all that. So he's here. Somebody wants to talk to him. He just left to go to the patient track. But anyways, I hate to say Steve is not here. I can say something silly. There is a lot on the eyes of the beholder, right? I'll leave at that because I think we all give 2 months, 3 months or something. But if we don't see that, nothing happening. The magic word here is fibrosis, which is a nightmare. We may have now a tool to address that, but the reality of the matter is, for example, right? I mean, if you have a given angle to, failing to extend your arm, you're going to measure that angle a little bit. So there are ways to measure that a little bit, but especially when it's very fibrotic. We all know here, those who are in this field, know that that's a very subtle thing sometimes, and then obviously you rely on how the patient feels, which adds another degree of subtlety on this, but ultimately that's what matters, right? It's not how I feel, but how he or she feels. So anyway, so I'm not answering at all.
So for me, yeah. So when I talk to my patients who are starting treatment, I acknowledge that if they have a lot of fibrotic disease, we may not see a lot of overt improvement for months, if at all. And so I think that this has been shown in some of the more recent clinical trials as well, is that these patient-reported subjective improvements are very, very meaningful. And what I'm hopeful for in these patients is because they're feeling better, what's happening is we're getting better control, even though we can't really reproduce this on physical exams or testing or things like that. And so I'm hopeful that with time we will start to see more objective improvement, but that subjective improvement in symptoms, improvement in ability to do activities they enjoy and go to work or to school, to me are very meaningful outcomes. So if I'm seeing that, that tells me that we're on the right track, and I will continue with what I'm doing at that point in time if I'm getting that report, but not seeing anything that's showing me very clear and overt progression of disease at the same time.
Needless to say, I'm sorry, Beth, I probably interrupted you, but not to mention that, to add complexity to this, again, I know most of you folks are familiar with this, but there is mixed responses, right? I mean, sometimes, hey, I have a little liver function test abnormality, and then it's a little bit better, but you talk to the patient, he doesn't care because, he's still feeling miserable. Hey, but your liver looks great, but he doesn't feel that. And so there is sometimes a huge discrepancy between you and I and who's there and tells us, okay, dude, your labs look great, but I feel horrible. So how do you measure that, right? I mean, so this is where the patient scores and such come in.
I agree with everything that's been said. I'll just add in terms of adding treatment. So I was going to say the same thing about oftentimes seeing mixed responses. So if something is not completely resolved or the patient doesn't completely feel better, although there's really no data, acknowledging no data for it, many of our now treatments or FDA-approved agents do have different mechanisms of action, different toxicity profiles, and has been shown at least in series that's safe to do. And so I will often consider adding additional treatment. In general, I do, in the absence of toxicity or clear progression, I do wait 3 months before considering additional or changing of therapy.
No, I mean, I agree with you guys because, but in BOS, sometimes, patients end up being on multiple therapies because, I'm not seeing response, but we're like, well, but this is a new mechanism and you're tolerating all this all so well. So it's really tricky. I will also say to Marcus's point about like the discrepancy, Joseph Padal and I looked at this in the chronic GVHD consortium data and also looking at it in some of the clinical trials, the larger clinical trials in chronic GVHD that there's poor correlation between patient-reported response of how they're responding, clinician response, and NIH response. And so it's like you need all three to sort of like, they're all three contribute something, right, in deeming response or determining response. So anyway, I think it's really tricky. Because we started late, we're short on time, and I want to make sure to give Dr. Shaw her time. So I will just end the case there, but I think these are all topics for ongoing discussion. I'm sure we could have spent a lot more time talking about these topics, but I want to thank the panelists for doing this, especially so last minute, and for answering these difficult questions. Thank you. Or not.